Hey, girl gang, it's Dr. Joy here, and you are watching Delivering Joy MDTV. Welcome to Well Woman Wednesday, honey. And have I got the topic for you, honey? Yes, this is the real tea, the super hot tea. So, I've been promising you that we are going to talk about your sexual health. So, I guess I should throw in some disclaimer about this being for mature audiences only or something like that. But honestly, as a gynecologist, I am a big fan of teaching your young girls about this, about their bodies, about their sexual health, so that when they do become a mature audience, they are ready and prepared to deal with all these things. So you decide how you want to work this, but today we are going to be talking about sex, baby. Let's talk about you and me. Let's talk about all. Okay, I'm sorry, I'm getting carried away. But anyway, I have a very special guest today who is an expert in female sexual health. So you want to make sure you keep watching. We are back. Super special guest for you today. And honey, this is pure Black girl magic. Her name is Dr. Maria Uloko. She is a urologist who specializes in the treatment of female sexual dysfunction, female sexual pain, low libido and desire, regenerative erectile dysfunction. So she does a little bit for the fellas too. And she is just phenomenal. She is a strong advocate for her patients in improving the quality of their lives. She has a very extensive resume, and I'm going to include the link to her bio in the description box. So make sure you check that out, because I want to jump right into this conversation and welcome Dr. Maria. Welcome, Dr. Maria.
Hello, good morning.
I met you at a conference in San Antonio, Texas, and yes. I was blown away by your presentation. First of all, you said, I wish they had Beyonce for me to walk out to here. And I thought, yes, this is my spirit sister.
Yes.
I mean, I thought the conference talk that you gave, which was kind of for physicians, was amazing. And I thought, I have got to get her to talk to my girl gang. So thank you so much for joining me today. Tell me a little bit about what you do every day. Sounds like fascinating work.
So, like you mentioned, I'm a urologist, and I specialized in comprehensive sexual health, which means that I take care of all genders in terms of sexual health. And, it's a very unique niche, and very, very fun niche. And so on the female or the vulvar side of things, I'm also the director of the vulvar health clinic at UCSD. And it's one of the really interesting things about being able to take care of all genders on the sexual health spectrum is really understanding the stark differences that they have in their needs and their access to care. And I think that's really been one of my biggest passions, is closing that gap of access to care and research. And so I spend a lot of time either talking to women or people with vulvas about their sexual health, teaching them about their anatomy, basic things, destigmatizing things, or, talking to my male patients about their anatomy and teaching them about things and destigmatizing things. My real big goal is to destigmatize how we look at sexual health and really look at it as it's actually health. It's not just, quote unquote sex, depending on how whatever cultural thoughts that you have about sex. It's really actually biology. It's health. It's a really important part of life. So if I'm not seeing clinic patients, I'm doing research. If I'm not doing research, I'm doing speaking, because I really want this information to get out there.
Well, I'm about to put it out here today, because I, deal primarily with people who have vulvas, or women, whatever you identify as a gynecologist. So I think that for me, talking about anatomy is really, really important. And one thing that you brought up at the conference that I had never even considered is that sometimes women can have some sexual function problems because of things like not being able to retract and clean under the clitoral hood. That was amazing to me. So tell me more about how anatomy can really affect sexual health.
Oh, yes. So anatomy is a huge thing. And then we're going to bring in culture. I'm always going to bring in culture because culture really shapes how we've treated the vulva and the clitoris and all of those things. It's not been looked at it from a purely scientific form. There's always some sort of cultural stigma and shame to it. The fact that the clitoris and the penis are the exact same structure, and yet, little boys are taught how to pull back their foreskin and clean underneath the areas. And then, although they're the same structures, little girls are taught, don't touch that, don't look at it, let's not even go there, which ultimately can lead to something called clitoral adhesions when you're not learning how to clean and retract and pull back. And those clitoral adhesions can lead to desensitization or decreased sensation of the clitoris, or even pain with arousal. And so that's where history, culture, science meet, where I'm seeing disease processes or diseases or conditions that could easily be prevented, but the only reason that they're actually even happening is because of cultural norms and cultural shame. And so there's so many there's so many physical things that can go into how we respond to sex and sexual stimulus or input. And I spend a lot of time teaching my patients, teaching people about, what does a normal, healthy organ look like that's going to help us get to whatever sexual goals that you
I
have.
have been amazed at how many women do not understand their vagina, just their physical anatomy, like what's there. And so if you haven't seen the video that I've linked in the cards above about just your anatomy and understanding what's there, like your urethra, your vagina, and your anus, and then your vulva and your clitoris, make sure you check that out, because that's something that you're going to definitely want to know about. It's very important. I think it's very important that women take a look down there. Like, you need to know what normal looks like for you, and also to see, like, because I see a lot of folks coming in all the time who have buildup of just debris, especially between the large lips, or the labia majora and the labia minora, and they're constantly getting like yeast infections and things like that. But it really is just they need to clean a little bit better, and they are saying things like, well, I'm using a loofah sponge, or I'm using whatever, and I'm like, well, you really have to kind of get that debris out, because you've got dead skin, you've got all kinds of stuff stuck here, toilet tissue, and just so you really have to kind of be a little bit comfortable touching there, looking there, being very proactive with taking care of that area to achieve your sexual health goals. So moving into a little bit about what we really want to get to, which is the heart of the matter, right? I see so many folks who are dealing with decreased libido, and they'll say, I just have no urge at all. I don't know what's going on with me. I used to have a normal libido. Now it's just totally gone. How do you approach those folks?
Oh, I love low libido because that's where I begin to become a detective. So I always start with my patients that the sexual response, how you feel sexual, is more than just one thing. There's so many factors that go into it. There's the biology factors. What is your body doing? Is your body in tip-top shape for being able to respond to sex? There's social factors. We're currently living in year 2.5 of a pandemic, and there's war happening. There's just violence happening everywhere. These are social and cultural factors that could also potentially increase the stress, not potentially, increase the stress response, which we know decreases the sexual response. And then there's interpersonal factors too. Studies have shown that women that are in the household have higher rates of responsibility. And so, if you've got like 90 tasks, sex is probably going to be the last one, getting the kids fed, getting to work, making sure dinner's at home, all of these things. So it takes a lot of different factors in together. So I approach this from the biopsychosocial factor, knowing that not only are there biologic or kind of physical things that we can fix and reverse, but then there's also the social and the cultural things and the psychosocial things. I always say the head is your brain is your biggest sex organ. If your brain is not there, you're not going to be there, no matter how perfect everything is, how optimized everything is. So I strongly recommend always having some sort of mental health sex therapist, mental health providers with maybe a sexual health background is really, really important. And giving yourself grace for those things, because, unfortunately, this is just where we're living at right now. But if we're going to go straight just solely from a biologic, how are we doing physically? We start with a very, very thorough history and physical. So there are so many things within the history that we can gain. So a lot of medications can cause decreased libido, some previous surgeries, some hormonal issues. I want to know where your menopause status is. Are you taking oral contraceptions? Because oral contraceptions can also lower your hormones. So can menopause. I want to then do a physical exam. I want to know, is there anything in your anatomy that could potentially be causing decreased sensation? Because if you can't feel, it does not necessarily want to drive you towards having sex or feeling sexual. And so there are certain people that have decreased sensation due to spine issues. There are certain people that have decreased sensation due to pain. If you have pain with sex, every time you have sex, it hits this negative feedback loop. Like, oh, I have sex, I have pain. It's not going to make you want to have sex. The decreased sensation in the clitoris, and that can be from the clitoral adhesions. Again, the clitoris is one of the most amazing structures. It is the only structure that's meant for sexual health. If your clitoris is not functioning correctly, it's going to be much harder for you to get to orgasm. And that's one of the main ways that women and people with vulvas have orgasm. And so if you can't feel it, and because there's clitoral adhesions, you also cannot get to it. So I take the low libido patient as just kind of like, okay, we're going to play detective, and we're going to then try to optimize everything that we can from a physical standpoint, from a historical standpoint, any medications that we can change up, all of these things. Also knowing that getting the mind right is going to be a huge factor too. And so I work really closely with my mental health providers on how to make sure that people are optimized and ready for when they want to have sex. Because the fact that they're coming into my office means that it is something that is important to them, and they do want to get it better. And so, they're all already highly motivated people.
Yeah, and I think that is what you talked about, is one thing that I talk to my patients about all the time, is that the brain is your biggest sex organ. And if you're not already there here, you're not going to get there in your genital area. Never. Mm-hmm. Because if you're not turned on mentally or stimulated mentally, it's going to be very hard to be stimulated physically. What's on your mind? How do you feel about your partner? Something that you need to maybe have conversations about with your partner. Or there's some barriers to you feeling sexual around your partner. How do you feel about yourself? Because I have a lot of patients that say, I feel disgusted when I look at myself in the mirror, or I don't feel sexy. I don't feel like I look sexy. I don't want to take my clothes off in front of my partner, that sort of thing. So yeah. I think those are all huge drivers of low libido. Would you comment some on the medications that you were describing that we might want to look out for? Maybe just the top 3 or 4?
Yeah, so the most common medications that can cause decreased libido are, like I said, oral contraceptions. Those can, depending on which one you do, those can definitely decrease your hormone levels. SSRIs or antidepressants are a big one. Those, although, as we talked about, there's getting the mind right, but also some of the medications or the treatments that we have to get the mind in a better place or decrease our libido and our drive to have sex. And so in those patients there are newer options for medication. options, and usually with newer options comes cost, but they can work with your insurance, because this can be a side effect of the medication. And if you have side effects of the medication, you can then, insurance will be a little bit more lax or willing to pay for the newer brands of medications that have less of the sexual side effects. Thyroid medications, if you are either hypo or hyperthyroid due to certain medication, can also decrease your libido. So any kind of medication that can potentially increase your serotonin or decrease your dopamine can affect your libido. But those are the biggest ones that I see in my vulvar patients.
Let's talk a little bit about folks who have difficulty achieving orgasm. I read somewhere that quite a few women, I think it was something like only 40% achieve orgasm by penetration alone. And so there has to be stimulation, clitoral stimulation, along with penetration, or clitoral stimulation alone. So how do you counsel folks who need, they're like, I can't get there. Like, I just can't make it there to get that orgasm.
I deal with a wide breadth of patients. So whenever I had an orgasm patient, a patient that comes specifically for orgasm, the first thing I ask them is, I ask them several things, but the first thing in my head, I'm trying to get an understanding of, can they orgasm, yes or no? Because that's a huge, huge factor. There are certain people that cannot orgasm no matter what they try. And those are people that tend to have some degree of some spine issue or some nerve issue where they actually cannot feel their genitals. So if you cannot feel something, something's going to, it's not going to work. All right. And so I have to classify those into two patients. So I actually ask every single patient that comes in, do you masturbate? Because the statistics shows that, only, I think it's like 63% of people in heterosexual couples that have vulvas orgasm versus almost 93% of people in lesbian relationships have an orgasm, right? So there's definitely a mismatch in the conversations that are happening between people, between the species of, this is how you orgasm and this is how you make someone orgasm. There's a total disconnect in terms of how people are doing the thing. So my first question,
that's a big gap.
It's a big gap.
Whoa, you need to step it up, gentlemen.
Yeah. Well, I think for like I said, I take care of men, people with penises, and their rhetoric is penetration. They aren't coached on the clitoris. Like, they should be, instead of like hyper focusing on penetration, it is a very important part, but it is not the most important part to getting people to orgasm, the most people to orgasm. It is very important, but it's not the most important part. But their messaging is penetration, which actually doesn't make sense from a scientific standpoint. So it's like, we are teaching the other team how to not succeed well. And that's just the history.
It seems like we're setting the partners up for failure here.
Exactly. The messaging is so different. And I think one of the reasons why I get to, because I treat all genders, and so I get to hear the messaging and I get to see these things, and I'm like, this is wrong. Everything is wrong that we're teaching you people. The first question I ask all of my patients that come in with vulvas, my women patients that come in and say, I can't orgasm, I first ask them, I need you to go home and get a vibrator, because I need you to just know, can you orgasm, yes or no? It's a lot of people solo can orgasm without a vibrator. And it is a question of, can I do it with a partner? And so I want to take out that partner thing, because that can confound or confuse things. And I just want them to literally, for 2 weeks, just try different things, different products on their own, different ways, and get really in touch with their bodies. Because if it is really oh, I just can't orgasm with my partner, or, oh, I just can't orgasm in this situation. That's not a biologic thing. That's not something I can fix. Because again, I am a surgeon. I do want people to know that. So what I do is I tell people if we're playing doubles tennis, what I'm doing is I am training you. I am giving you a tennis racket. I am going to give you all of the tools that you need to get out there and play the game. I will not be your coach. That's where the sex therapist comes into play. That's where you come into play. That's where, figuring out how to do these things come into play. I just make sure that you are properly equipped, because sex is oftentimes a team sport. And so, you need, I equate it to doubles tennis, both partners need a racket, both partners need to be optimized and trained, and their bodies need to be right. And that's where I end. So if they go home and complete the assignment, I'm a very fun teacher. My homework assignments is oftentimes, can you orgasm, right? Like I just go home and say, go have sex. But when they come back and they say, actually I did, and it was good, I can, then I'm like, okay, so these are some medications that we have to kind of optimize your response. But I'm going to also strongly recommend either partner workshops or online workshops, or even going to a sex therapist to then help you get better with being in tune with your body, being in tune with your partner, so that you can actually, when you're actually doing the act of having sex, you're present, you're engaged, and also when I have my male patients come in with ED, I talk them too about, hey, the erections is very important, yes, but how are you taking care of your partner? And I teach them about the clitoris. I teach them
there's more than one way to skin a cat.
Yes, exactly.
So, yeah.
And so I'm having the same conversations with my male patients too. I'm like, hey, by the way, this is important, but I'm also going to teach you on other, the clitoris, this and that and this, and these are the statistics, and this is actually what they need, and not just you're having a rock hard penis. It's very nice and lovely when it's there, but it's not the only way to have sex. And I really destigmatize and really, really kind of try to frame this mindset of, oh, there's more than one way to do this. Like you said, more than one way to skin a cat. And then we go from there. And then the other side of the algorithm or equation is, if you are really someone that you go home and you've not been able to have orgasm, even with the best toys ever, then that's actually a real biologic reason. And that's where we start just exploring any sort of spine issues that you might have. Much like people can develop sciatica or leg numbness and tingling, you can also develop kind of sciatica or numbness and tingling in the genitals. They're all the same nerves and organs. And so we need I put those patients on that algorithm. But a lot of it is always trying to figure out, can you actually have an orgasm, yes or no? Is the messaging that we've been teaching, heterosexual couples, that one needs to have penetration and the other one needs to just take it, even though their sexual organs teach them sexual organs are not actually meant for just that. It's a very coordinated, complex system. Is it the messaging that we're doing? And then if it is, there's these options. And then if it isn't, there's this option. So I think our culture of virginity, I'm fighting our culture of purity, and fighting this culture of shame, when in reality this is medicine, this is actual biology.
I think that is so true. The culture of shame is really strong. People don't want to talk about their genitalia. They're very embarrassed to just say the word vagina or penis. I have my favorite reference to a vagina is the sugar dish. Someone came in and said, my sugar dish, something's wrong with my sugar dish. So, I hear all kinds of crazy nicknames to try to just avoid saying the words. And I'm always very quick to ask, well, have you taken a look to see what's going on, or the area that you're concerned about. And probably 80% of the time, the answer is no. People will say, I just want you to look and see if this is a skin tag or a wart or what it is. And I said, well, have you seen it in the last, year or so? No, I don't look down there. Like, there's a bump. Like, what is it? So I think people get very, very uncomfortable about it, even to their partner. And they don't really want to look at it, touch it, and I'm like, wow, this is a part of your body. It's a magical part of your body. This is something that you should be well acquainted with, that you should know what it looks like. You should be able to clean it properly. You should understand how it works. Like, this is yours. It's yours. It's like, I don't know. It's like your car. You get to drive it off the lot. You get to keep it. It's all yours. You have full license over it, full autonomy over it. You get to decide who touches it, when, where, and how. And, hopefully no one violates the autonomy that you have over that. But I just think it's so interesting how we all just have this real timidity towards the sexual organs. And maybe it's a little easier if you're a gynecologist or a urologist and you look at it and talk about it all day. But I just wish we could find a magical pill to help people to somehow wake up to the knowledge of self and be very comfortable talking about touching and being very aware of their sexual organs. But I have a question for you, because I think this is kind of somewhat controversial, but I hear people talking about this G-spot. What is your take on the G-spot? Does it really exist? And I hear that it's somewhere maybe like 4 centimeters back on the anterior portion of the vagina. Mm-hmm. Is it really, really there, or is it just a bunch of like malarkey?
Yeah, no, it's there. It's definitely a thing. And we are actually trying to go away from the terminology G-spot to call it the G complex, because it incorporates the clitoris, the bulbs of the clitoris, the vestibule, and the anterior vaginal wall. And so it is a thing. It does exist. So the confusion as to where and why the G-spot does and doesn't exist, again, is one, rooted in cultural malarkey. So whenever they do anatomic dissections, it's usually on someone that's much older, and it's usually on, and they've been dead, obviously, because they have to be dead. And they tend to be much older. And so we know that the G spot or the G zone is very androgen and estrogen, so very sensitive to hormones. And so now you're trying to do these dissections on bodies that haven't had hormones for 30, 40, 50 years, and so it oftentimes gets missed. But there have been MRI and functional studies. There was a whole article on this recently in the Review of Sexual Medicine on reclassifying these things. But yes, it is not something that should be up for debate. It is an actual anatomical thing, and it's actually a really interesting kind of pattern that we see in vulvar health, especially when it comes to sexuality. There's always so much controversy when it comes to just anatomy, right? It's like it shouldn't be controversial. Does it exist? Yes or no? Like the clitoris, until 2005, there was not a full documentation of the full extent of the clitoris, right? It wasn't until 2005 when a urologist, Dr. Helen O'Connell, was the first one to map it out. 2005, right? And if you look at the history, it was just a bunch of men arguing about whether the clitoris existed or not, which again, we can make so many jokes about that, but it's like, what are we talking about?
They really didn't know it existed. They were very confused about it.
It's just wild when you see how much the culture of shame, of shaming sexuality, especially female sexuality, starts playing into the role of science. Like, that's what makes me angry. This field that's supposed to be super objective. We only focus on the science, when actually, if you look at female sexual health, a lot of the science has been taken out of it, and it's really just been like, okay, what do these men want? What do these men get to decide about our bodies, which is like, makes me angry. It makes me want to burn some things down.
Absolutely. You know, coming up into OBGYN, most of my teachers were older men. And you can just see there's definitely kind of a stark difference. And as more women are coming into the fields of gynecology and urology and general surgery, you can see kind of like a movement, a shift of away from paternalism. Like, we don't get to just decide what happens to female bodies. We have to talk to people and ask questions and understand, help them to understand what the options are, and then let them choose what they think needs to happen to their body.
I love that.
And I think it's really high time that the paternalism in women's health die out. It's time for it to go. We don't need to just be because it makes me super, super mad when women come in and say, hey, I had a hysterectomy, and I'll say, well, what was that done for? And, well, I don't know. They just told me that it had to be done. And, I'm just like, what? Like, you just did a whole life-changing surgery on this individual, and they don't understand why. And I think that for a long time, women accepted that. But there is a shift of women who are very much demanding that they understand the options. They're seeking second opinions. They're asking questions. And that's really what needs to happen in order for us to take back our reproductive health and rights. So yeah, the power. So, I wanted to ask you a little bit about conditions that cause pain during intercourse, and how we can kind of map those out, because I know a lot of folks experience pain with intercourse, and that, like you said, creates that negative feedback loop to where, okay, that hurts, I don't really want to do it. And they may even have the desire to try to push through just so that they can please their partner, but every time they try, they're like, oh my gosh, this is really bad, this is really painful, and it can be really difficult to treat. I know for myself as a gynecologist, I'm like, oh my gosh, I'm trying this, I'm trying that, we're trying pelvic floor therapy and topicals and just all these things, and sometimes it doesn't get better, and it's so frustrating. So how do you approach conditions that cause pain during intercourse?
Yeah. Like you said, pain is challenging. And that is actually a big focus of my clinic, is pain. And so one of the beauties about my fellowship is that I got a really good algorithm for pain. We were very much a pain center of excellence. And so having that background and kind of having a really good template of how to diagnose and work things up and then treat. So there's so many factors that can cause pain. So the official terminology now is genital pelvic pain penetration disorder, or GPPD. So, and when we look at GPPD, the most common cause of it is called vulvodynia, which is a very general term, which just means there's pain in the vulva. So, which is like not all that helpful. But when we actually then look at the most of the things that causes vulvodynia, something called vestibulodynia is the most common. So 90% of vulvodynia is from vestibulodynia. So just all of these words, all of it is just special words for there's pain in the vulva, and then we break it down and actually localize the pain, and most of it is found in the vestibule. So that's how I approach pain. So outside of getting a really detailed history, I want to know more about you. I want to know when this pain started, how this pain has affected your life. I want to know, are you still able to have sex? Yes or no? I want to know, a lot of people have a trauma history, whether it is like physical trauma or even the emotional trauma of repeatedly putting yourself through these painful experiences. I want to know your medical history, any prior pelvic surgeries, any prior vaginal surgeries, prior births, medications that you're taking. And we talked about birth control is one of the medications that can cause a lot of issues. And it's very needed, but it can also cause issues, and just addressing the sequela, or like the side effects, is also very important. certain cancer treatments, certain acne treatments can also cause pain. So really getting a very detailed history. And then when I look at doing an exam, I try to take that terminology of vulvodynia, meaning pain in the vulva. There's somewhere there's pain, and I try to then figure out where the pain is. And so I do a very detailed vulvar exam. And I have every patient look with me because I'm teaching you your anatomy. Because one of the issues I've looked at is from several prongs. One of the issues is that patients don't know how to explain where their pain is. And that's because, and it's no fault of their own, it's because you don't get good sex education. You've then been told your genitals are dirty, unclean, do not show them to anyone. And so you don't learn to learn your anatomy. And so when you go into the doctor, you don't know the phrases to use. You don't even know how to describe where your pain is, what your pain is. You're just like, it hurts down there, which, that's really hard for clinicians to know how to do this. So I train and teach my patients how to, when you go to someone else, describe your pain, because that's going to be really, really important, because I know how hard it is for them to get in front of a provider that even listens to them and like knows, and it's harder for providers to listen when they don't know and they're not speaking the same language. And then two, then we've localized where their pain is. If you can localize the pain, then that's the source. And a lot of the times it is coming from the vestibule, but people can then also have pelvic floor issues because there's a driver for the pain, and then the pelvic floor is then responding to the pain. And so you can get really tight, sore muscles that can then make the pain worse. Or some people just have pelvic floor issues without any other issues, and that can also cause a lot of pain. Once I localize the pain, and like I said, most of it is really in the vestibule, and getting an understanding of whether it's penetration pain. So there's pain when you first insert the penis or whatever device, first insert anything into the vagina. And that's called penetration pain, like superficial penetration pain, versus do you have pain when whatever device that's penetrating you, whatever it's penetrating you, is hitting deeper in. So like the cervix, if it's hitting the cervix and you're having pain, that's usually something called endometriosis until proven otherwise. So I also elicit that from the history. And then on the exam, I've localized where the pain is, figure out if it is in the vestibule, if it's in the pelvic floor muscles, if it's in the clitoris, treatment plan based off of where the pain is. And then from there, I get a complete hormone panel, because all of this tissue is very dependent on hormones. And if you have an abnormal hormone panel, that is going to affect those tissues. And so I kind of do a very holistic approach. And again, I take it from the biopsychosocial model, where I'm treating biology. I'm figuring out, is there something biologically wrong? And I also use my physical therapist. My pelvic floor physical therapists are like my best friends. They're truly amazing. And I also use sex therapy, because again, this is really traumatic for a lot of people to constantly be going through that pain fear cycle. And the terminology vaginismus is actually the psychological fear of penetration, because you've had this negative feedback model. So although, let's say we fix the biology, we fix your pelvic floor, but if you still have that psychological fear, we're never going to actually fully fix you. So that's why I take that holistic approach, because I can't look at you as just one factor. You're a whole human being. And it's so important that we address pain from that standpoint, because if your brain's not there, we can fix everything. But again, your brain is your biggest sex organ, and it is so important that if your mind's right, everything else will follow.
So huge. I need a class. You need to have a class for gynecologists so we can get this better, because what you just said was probably more information than I got in my entire residency. So, because nobody really wants to deal with with painful intercourse. You'll get a little bit of information here, a little there. Oh, use this medication, throw a little topical there. Put a little vaginal Valium, or try this or try that. You can do Elevate, just kind of like bits and pieces. It's very piecemeal, but thinking about it from a biopsychosocial approach is actually a lot more fruitful for the patient, and I think too for the healthcare provider, because you have a systematic way about treating this, and it makes so much more sense to do it that way. And I think you'll have better success, because what generally happens is I see patients all the time that say exactly what you said. No one listened to me, or they tried something, it didn't work, and then they were just like, well, I don't have anything else for you. Find somebody else to help you. And so it can be really, really frustrating for folks who are dealing with this. And it can be really frustrating for providers too, if they're not really well trained in this area. And most programs are not giving you a whole lot of training in vulvodynia at all. So you're just kind of like, let me see what I can find on, up to date or whatever. So it's definitely challenging for both patient and provider. So tell me a little bit about how you think the pandemic and all the stress that folks have been experiencing has affected. Like, have you seen a big jump in the number of patients that you're seeing right now?
I have, actually, and I think this was the first time in our capitalist model where people were ever allowed to slow down and check in with themselves. Because, when you are used to getting up at 8 to be in the office at 9, and then you work all day till 5, 6, I'm just saying this is a 9 to 5, and a lot of people don't have 9 to 5 jobs. And then you have to come home, and then you have to deal with children, spouses, partners, all this other stuff. And then rinse to repeat. You don't actually get time to like pause and breathe and be like, wait a second, what about me? And so I saw that we had quite an increase in people wanting to just take care of themselves. And, I think a lot of the culture that we live in talks about delayed gratification a lot. And the pandemic was the first time that people could see that, like, oh, if I delay life, it could be gone at any minute. And so it's been really lovely to see people taking ownership of their health. When people think about sexual health, they always think about it as like the bottom, like some frivolous thing. And I'm like, actually, there's a lot of other things that go into sexual health. Like your overall health really is a reflection of your sexual health, and your sexual health is an overall reflection of your overall health. And so if we really think about it like that, it was really empowering to see so many people start caring a lot more about this very important facet of their health. Granted, now, every day is a new day, and I have no idea what's going to happen tomorrow, but that's the upswing that I saw, was actually people wanting to take care and address these issues that they've been putting off.
And, one thing that I talk to patients about a lot is, sexual health is indeed health. So what you're eating, are you drinking enough water? Are you exercising? Like, these are all things that do affect your sex life, believe it or not. Your stress levels, how much sleep you're getting. These are all important things, because you want, if you're talking about your energy levels and your desire to have sex at the end of a long day, like, taking care of your physical body actually does matter when you're talking about these things. And so folks will expect high performance from their bodies that they're not taking really great care of. So you're not going to be swinging from the chandeliers if you if you're not eating well and resting well and exercising. And so you're not going to be able to do some of the things you were doing in your 20s if you have kind of let go of your overall health. So it's important to keep those things going. Like, if you've developed hypertension and diabetes and all of these things, and they're not controlled, those are going to affect your sexual health. So it's important to take care of you overall in order to be able to experience a healthy sex life.
Yes, yes, very much so.
What thing, if anything, what's your number one thing that you want to say to the girl gang today about their sexual health? Like, what are your final parting words, your words of wisdom to us to just embrace our sexual health and to be healthier sexual beings?
Yeah. Oh gosh, I have so many things. Um, let's see. I think the biggest thing is, there is no normal when it comes to sex. Do what feels good for you, right? As long as we are all consenting adults, really owning your sexuality and your sexual health is really one of the most powerful and liberating, and kind of a big fuck you to the man. I don't know if I can use those words, but it is such, there's so much liberation when we think about sexual health and owning our bodies, because who has been telling us that we shouldn't own our bodies, right? Who has been telling us that we should be ashamed of our bodies? What messaging has that been? And so when you stop thinking about sex from that standpoint and really thinking about, I love my body, I like the way it feels, I want to get to know it, there's something so liberating and so powerful about that. The other thing is, when you're dealing with healthcare providers, I think one of the most important things is, and granted, this is hard. It's not easy for everyone. Is that understanding, when you have that mentality that this is something that's vital for me, is you won't let people dismiss you, and educating yourself on your body and what feels right. And you once you start knowing those things and start researching those things, when you go to the doctor and they tell you, no, that's not real, you can then say, actually, it is, because you know a lot more about your body than any doctor can ever know. You live your body every single day. We meet each other for 30 to 45 minutes, if that. And I tell my patients, you are your ultimate person. Like, I am only here to give you advice, but you ultimately know your body, you know your lived experiences, and you know what you want. So get in touch with your body. Stop saying it's shameful. Don't say your vulva or vagina is ew, gross. Like, it is one of the most amazing things, most like truly scientifically complex things, and the research is still out there that we need to do, and really just owning it and loving it and taking care of it is really so important.
I would wholeheartedly agree. Listen, Dr. Maria, thank you so much for joining me. We're definitely going to keep you in our Girl Gang Rolodex, because I'm sure there are going to be lots of questions and comments on the things that we've mentioned here. And we may need to take a deeper dive on some of these things, because, there's just so much wealth of knowledge that you have that you can share with us. We are so grateful for you coming in all the way from San Diego. That's a far place. I know you had to get up really early to do this, and we appreciate you. So Girl Gang, make sure you check out Dr. Maria and follow her. I'll be putting her information in the description box below. If you're watching on BTV, you can just head over to YouTube and get all this great information. Or if you're on Roku, same thing, head to YouTube, get the description box, and you can get links to catch up with Dr. Maria. So we're going to catch you next time, Girl Gang. Peace.